So I have the pleasure of spending time in Barcelona and in Boston. And in Barcelona, really the work of Life Brain N of the Barcelona Brain Health Initiative was enabled, and thanks to David Bartres and Cristina and the whole team there. So I have the joy of working with them, and I want to thank you for this opportunity to be here. It's been a great meeting so far. Thank you. I've learned a lot, and I hope that what I tell you is of some interest. So I have some disclosures. Harvard makes me do this, so there you go. Those are my disclosures. I promise not to tell you anything that is excessively biased, other than by my own beliefs, which of course are biased. But I will tell you a little bit about work done thanks to the Barcelona Brain Health Initiative, the work that we're doing in Boston at Hebrew Senior Life, where I work mostly in a facility that supports living of elderly individuals, healthy aging initiatives being one of the things we do on 15,000 people, and so it gives the opportunity to do a real living laboratory, which has been very exciting. And I will also tell you finally some things, or actually to start with, some things about digital biomarkers of behavior that are related to Linus Health, which I'm a co-founder of. I think it will not come as any big insight or surprise to any of you that I also share the view that we need a program for lifelong brain health and well-being. I'm a neurologist, I'm a behavioral neurologist, still practice. I know that when I see the patients, they come about 15 years too late for the beginning of dementia, leave alone for the beginning of the kind of lifestyles, behaviors, and otherwise that could potentially have precluded or at least slowed down the development of the dementia. The traditional approach in neurology and in medicine is that we just wait for the symptoms to develop. When you have an illness where oftentimes anosognosia is a big component of it, then the symptoms don't develop and you come to see the primary care physician, the symptoms develop. At some point, your loved ones become convinced that you have problems, and that's when they finally force you to go. So it adds an additional 3 to 5 years, as we now know. That said, at that point, we're really pretty good at making a diagnosis, and we're pretty bad at making a therapy that truly impacts disability. So we need to change the approach, and ideally, we should aim to promote brain resilience, to minimize the risk for the illness to develop symptoms, or even beyond, earlier than that, promote brain health to even minimize the risk of developing the illness itself. And that's sort of what was the motivation behind the Barcelona Brain Health Initiative, which compared to many of the cohorts you're well familiar with, this is a small one, but I think an interesting one in the 40 to 65-year-olds, healthy individuals, very committed to this study, and that we've been able to characterize quite nicely. Now, with that goal of changing the approach, I want to talk about 3 guiding principles. First, the importance of longitudinal assessments that aim for early detection, essentially regular brain checks that translate into actionable recommendations that have to be informed by sensitive measures and that should ideally start in childhood and then follow longitudinally across. I love Christine's basically saying the same thing, I think, and so it made me feel good, thank you. The second thing I want to talk about is that it's not enough to assess the behavior manifestation, but if we want to understand the brain as the source of that behavior, then we need to look under the hood, as it were, and we need to assess the underlying physiology that leads to those behaviors. And I'm going to argue that specific alterations of spatiotemporal signatures map onto the alterations of behavior. And finally, again, remember I'm a neurologist, I want to think about the possibility of, can we translate that, the identification of altered spatiotemporal signatures in therapeutic interventions that may promote health or that may minimize disability. And we've been interested in non-invasive approaches that might be personalized and home-based. So that's what I hope to tell you about. To start with the first thing, I think for the most part, you think about it from a generation's perspective, the first generation of cognitive assessments, behavioral measures are paper and pencil. There's lots we can learn from it. There's lots of limitations that come with it. Digitized versions of those tests, quote, second generation, streamline the process, including the process of integrating with other data from the patient's electronic healthcare records and otherwise, but add very little extra sensitivity and don't really add to the specificity improvement. It's not very different to do the exact same test and score it exactly the same way on paper than on a tablet. It may look cool on the tablet, but it's pretty similar. However, having the digitized versions of those tests allows to approach the assessment applying what is called the Boston process in neuropsychology that some of you may be familiar with. The idea that you don't need to wait for the output of the task performance. You can get a fair amount of insight on how somebody's doing on the basis of how they go about doing it. I think it's true for any job, for any task, for anything we do. You can tell that I have no idea how to mow the lawn when you see me try to set up the lawnmower. You don't need to see the end result. It would be dreadful. But the idea of capturing the process is what expert viewers, expert observers do when observing a patient. But we're limited by our attention, by our processing abilities, by our notation abilities, but technology is not. And so the argument I'm going to make is that by doing technology that captures process and is AI enabled to draw algorithms of that process, we can get exceedingly more sensitive and specific metrics of behavior in a much shorter period of time that can also then translate into specific actionable recommendations. So let me give you an example of that. This is a very classic neuropsychological test of a clock drawing test. I ask you to draw a circle, put in the numbers with the hand showing 10 past 11. And here you have two that are done by two different people, both of whom would have scored fully on output of the test. If you had not seen how they go about doing it, there is no difference. Each one of them would have gotten 3 points, the circle, the numbers, the hands correctly. However, if you digitize the process and you capture time-locked and spatially locked information about how they go about doing it, you can extract features. We settled on 140 of them that you can then let machine learning approaches characterize whether or not the performance was correctly and whether or not it was related to any one underlying abnormality. And when you do that, what you find in these two clocks I showed you is that the first one scored in the normal range, but the second one did not. And it did not on very specific deficits. The percentage of time spent pausing and thinking of the next thing to do, the latency on average across the entire performance, ultimately the bucket of metrics that we capture as information processing is the abnormality. But it also illustrates the fact that you could have a similarly normal output on the basis of drawing efficiency and motor behavior being abnormal, and it would give you a different pattern of path to pursue. Now, that can be done in 3 minutes by anybody. The most impaired people will take 3 minutes to complete a task like that. And you can extract exceedingly sensitive metrics. And Doreen Renz and others at the Harvard Aging Brain Study have shown that if you take a group of individuals who are cognitively intact by standard neuropsychological testing, including the PAC, and you look at the results of the PET studies in them, a subset of them, 40 of 143, are amyloid positive, even though they're cognitively intact, there's nothing abnormal, except the DCT clock that you just saw does identify those on the basis of specific metrics that differ between those who are amyloid negative and amyloid positive. So it's not that these individuals are asymptomatic, is that our tools are not sensitive enough to detect the symptoms that they in fact do have, or the deficits, I should say, that they in fact do have. Now the question of what exactly the metrics are that relate to specific depositions of amyloid in different parts, that's an ongoing question, I don't know, but it suggests the exciting possibility of having digital biomarkers that map onto biology. A similar study has been completed on tau PET. So the goal of this is to obtain these very sensitive measures, and the translation to clinic, the translation to public health impact of brain health would be to be able to extract from there not only recommendations for the providers of what to do, but also result summaries and action plans for the patients to actually be empowered as individuals to choose their lifetime brain health goals, something that we'll hear more, I'm sure, later today, and define with that the actions that they want to take. And of course, all the raw and aggregate data are available from these metrics for research. Let me give you another example. We've known for a while, thanks to Brad Manner and many others, Verghese and others, that you can have a physiologic metric of, quote, reserve if you assess a dual task cost. So if you put people on a forced plate and have them stand still, not moving, they sway inadvertently, and you can capture that as you see there. And when you ask them to continue to stand while at the same time do a cognitive task, say count backwards in threes, they sway more. It's hard to stand still. You also see that in the other way around, you're walking and you're walking with a particularly nice stride, and the conversation becomes particularly complicated, and you slow down and your stride variability becomes greater. Either one are measures of dual task cost. We can argue what that means vis-a-vis cognitive reserve or brain reserve. But if you look at the dual time cost, you can take it outside the laboratory, which we've tried to do, by having using the benefit of mobile technology that is basically capturing my walking, my stride, my stance, my posture as I go along doing that. And Brad Manner has shown that mobile technology with an instruction that gives you now do walk in a straight line while counting backwards, so it's an instructionally guided task, gives you as precise data as the lab one. But I think it's even more exciting is that the phone in my pocket, normally my pocket, now over there, it knows when and how I'm walking, and also whether I get a call and whether I answer it, and how I'm talking and how interrupted or not my fluency is. And so you can envision that same task done unobtrusively through the ongoing process of walking. Again, another application of this sort of digital biomarkers of behavior. And I think there is a lot that we could extract in cohort studies by starting to capture such metrics. Now, to switch to the second guiding principle I was talking about, those behaviors, any of those behaviors, as well as any emotion, cognitive function, and so forth, are ultimately the manifestation of a given brain structure giving rise to a given brain function, which could be characterized by a spatiotemporal signature. For example, with high density EEG. If you have an illness, a stressor, an insult, any such thing, there's going to be a disruption, potentially of brain structure, and probably of brain function with an alteration of spatiotemporal signatures. I believe those map the proximal cause or substrate of symptoms and disabilities. If that is true, then one can think of disabilities related to the brain as circuitopathies ultimately, regardless of the, potentially, regardless of the etiology that gives rise to a given symptom, the alteration of the spatiotemporal signature may be similar, but perhaps more interesting again from a neurology point of view is the possibility it gives us a very precise, personalized, unique map to target, so that if you can restore the quote unquote normal spatiotemporal signature, then you could impact the symptoms and potentially impact the pathology. So is that science fiction, or is there any support to that? This is work from Recep Özdemir, building on many years of brain stimulation combined with imaging, in this case TMS that Heidi mentioned a little bit, but single pulse TMS, and looking at fMRI guided guidance to be able to target a specific functional target, fMRI guided stimulation, recording the impact on high density EEG of that stimulation. And the part of the work from Recep I want to highlight is that when you look at the characterization of any one individual with 5 brain regions targeted, so perturbations to 5 brain regions, then you end up getting a very robust individual fingerprint. Individuals may vary in the response in prefrontal, parietal, motor, and so forth areas, but if you look at an aggregate of at least 5 locations, you get a characterization of an individual fingerprint, which presumably means that there is a relationship to that rather non-physiologic perturbation that highlights something about the underlying brain functional state and configuration and dynamics. With that in mind, one can envision a sort of toy model of brain stressors, brain insults, or brain injuries, where you could use the perturbation by TMS to model any one insult. And then look at the local and distributed response to the stressor and see to what degree those kind of perturbation biomarkers are predictive of the real situation, real life consequence of a true stressor, insult, or injury affecting the organism. So a way to assess the individual risk for any one event to happen. I want to give you 2 examples of that approach. One from a study from some years ago from Kilian Avellaneda, and one more recent one that I think can be interpreted in that light I just described. So if you target the angular gyrus, then you can have an impact captured of that perturbation, captured in this case not by EEG but by functional imaging, and you can see an impact remotely because of the fact that stimulation has a network impact in medial frontal areas. And you can see a range of responses, and one factor that defines that range is age, being different in older than younger individuals. If you look at those who are older and have the top response that is similar to the response shown by a younger cohort of individuals, and compare that with those who have a different, much lesser remote impact, and follow them 3 years later and assess how they're doing cognitively, even though at baseline everybody was cognitively intact, those 3 years later who had the young-like response were cognitively better than those who had the old-like response, and in fact were better than they were at baseline, suggesting that this perturbation biomarker of, in this case, parietal frontal connectivity, it might be a valuable predictor of what is to come vis-a-vis many years later of cognitive function with probably very different experiences in between. We give you another example of that sort of approach with a much more recent and timely situation and much harder to anticipate. So thanks to the unique Barcelona Brain Health Initiative cohort, similar with we were hearing this morning from the biobank and from the UK Biobank, we had data on individuals before they were potentially exposed to COVID and then serially after. We had pre-pandemic data for 2 years, or 3 years in some of them, and then the state of emergency hit, and we were able, thanks to the work of the team in Barcelona, Gabriele Cataneo, Javier, and others, to respond to it and launch at specific time points related to big events within the pandemic, the lockdown, confinement, the de-escalation, and otherwise, serial assessments where we assess how people were doing in a variety of different domains, including cognitive and mental health. Not surprisingly, if you look at, say, the PHQ-9 change as an index of mental health over the course of that time point, you can look at it 2 different ways, but you basically find some folks that got better and some folks that got worse. Overall, there was an impact that was negative, but there were certainly many who seemed to be helped by the stressor or cope with it better, at the very least, that were more resilient than others who were more vulnerable. And because we had the data of these spatiotemporal signatures, perturbation biomarkers from years before, in this case before an unanticipated stressor, Ruben Perellón was able to look at it and look at whether there were differences or not in those who were resilient versus those who were vulnerable in response to a prefrontal versus a parietal perturbation with TMS. And what you see here is that in response to the dorsolateral prefrontal cortex stimulation on the left, the individuals who later on turned out to be vulnerable for mental health consequences had a very different pattern of response to the TMS perturbation than those who were resilient. That was not the case for the parietal target. Remember, that parietal target is the one I just showed you a moment ago, at least from MRI, was potentially predictive of the cognitive decline down the road with age. And that effect of the local reactivity to TMS accounts for some portion of the variability of the PHQ-9. So those are 2 examples of this potential utility of characterizing the spatiotemporal signature in response to a rather artificial perturbation, these perturbation biomarkers. I want to finish up by asking the question, is it possible to modulate those signatures and promote brain health and reduce disability as a home-based intervention? And for that, we've been using transcranial alternating current stimulation. And the idea is you can use high-density EEG, as I was mentioning, in relationship to the TMS perturbation or in relationship to a cognitive task. You can identify not simply the source, but the spatiotemporal signature of that behavior. And then you can optimize a montage of electrodes to that spatiotemporal signature, taking into consideration both the spatial information and the temporal information, hence the alternating current. So to do multifocal stimulation, but to do it at an appropriate frequency. And we've been using the StarStim home system from Neuroelectrics, which allowed us to plan the treatment courses and then send the participants home with a tablet controlling the stimulation and sending remote access and monitoring cues to the study team. So let me give you one example of that. You take a cohort of 120 Alzheimer's disease patients, You look at their high density EEG. One thing that stands out is a deficit in gamma activity, particularly in parietal regions, with a source in the precuneus. So you can generate a montage that stimulates the precuneus at gamma frequency. And you can compare sham with real stimulation in two parallel cohorts of 60, I think 60 patients. Yeah, 60 patients. And you see behaviorally that there is a range of responses, but there is a significant improvement in cognitive function over the course of 3 months that sustains for another 3 months in those who receive the gamma stimulation versus those who receive sham. And in fact, the amount of cognitive improvement is correlated quite tightly with the amount of gamma increase induced in the precuneus area. But you can take that sort of approach and apply it across different cognitive functions and domains. So for example, you can identify the dysfunction mostly in frontal areas related to depression because of an alteration in dorsolateral to subgenual cortex connectivity. This is a very small pilot study in more feasibility than anything else, but it shows that intervention in people with medication-resistant depression significantly improves their cognitive function and their mood and again sustains for some time afterwards. For episodic memory in people with Alzheimer's disease, the target ends up being also gamma dependent or theta in angular gyrus, and you can do a similar proof of principle experiment. You can combine even more than one target and improve or aim to improve dual task cost and gait at the same time. So what I try to tell you is that we can benefit from leveraging technology for early detection, more sensitive measures of behavior, and ease of longitudinal assessments, that we can and should at the same time look at the underlying physiology, identifying the spatiotemporal signatures and their alterations that map onto potential changes in brain health, and that in doing so, it offers targets for potential interventions that can be done as personalized home-based interventions to promote brain health or diminish the risk of disability. Thank you.